Hello, good morning, everybody, and thank you, Susan, for inviting me to talk today. I'm going to try and talk you through the work we do in Leicester, the vulnerabilities we've uncovered, the icon messaging, and why I think it needs to be part of a big package and not an isolated standalone message. So I work at University Hospitals Leicester Neonatal Services, and in Leicester, our infant mortality rate is above normal or above average. So if you look at the child health profiles, this is infant mortality profiles which are set out by the government. Infant mortality is a very important indicator of health of a nation, and the infant mortality rate is classified as the number of babies that die in the first year of their life for every 1,000 babies born. And you can see Leicester's value is 6.9 per 1,000 babies. The national average is 3.9 per 1,000 babies. And therefore, for our birth rate of about 10 to 11,000 babies, for 10,000 babies, we have roughly 69 deaths, whereas if we were national average, we would have had 39 deaths. So roughly approximately 30 more babies die a year in Leicester compared to what is national average. And the risks and the vulnerabilities for these are multiple. The Leicester infant mortality trend is not new to this year or the year before, but has been with us since we began to monitor infant mortality. And on the immediate right of this graph, you can see 1870. It might be too small for your computers. The blue line is the national average. The red line is Leicester, as it used to be called. The middle graph is showing the same, but for the 1900s, and the immediate left-hand side is showing the same for the 2000s, with Leicester being the red and orange dots and the national average being the black dot. So Leicester's infant mortality rate, that means deaths of babies in the first year of their life, of those who were born alive, is and has been much higher than national average before the institution of the NHS and after the institution of the NHS. And so there are multiple, it alludes to the fact that there are multiple associations with infant mortality, not just with clinical health provision. So the public health associations, and this is commonly found in multiple areas that have had their scrutiny reviews for infant mortality, the associations are with infant health mortality, extremes of maternal age, smoking, lack of maternal education, maternal obesity. Ethnicity plays a role in multiple ways, domestic abuse, late booking, social deprivation, and for the infant, it's low birth weight, prematurity, lack of breastfeeding, infections, congenital anomalies, and sudden infant death. And as you look at all of these, you can see that the wider determinant for all of these is poverty, overcrowding, lack of perinatal care, and almost all of these are upstream of the birth of baby and pregnancy. And so in trying to address these, and these have been supported by multiple public health bodies and councils, what we developed is a parent education and support program to raise awareness around common factors associated with infant mortality and to support parents with up-to-date information on how to minimize these risks for their baby. And there are multiple standards that this piece of work meet, including Ockenden, NNAP, which is our National Neonatal Audit Program, etc., as seen on this slide. It's a philosophy that I firmly believe in, and that in as much as it is important for us to care for very sick babies born on the unit, it is equally, if not more important, for us to prevent them from being born too early. And that's what I mean about stretching the boundaries for what care we provide on neonatal and antenatal services. So the plan was to invest in a parent education and support program to raise awareness around common factors associated with infant mortality and to support parents with up-to-date information on how to minimize these risks for their babies. And the work is anchored at the university under the STORK program along the link that is shown on this slide. It's based on the principle that of participatory learning and action, where you, as in this population, where in Asia, families were told about the risks associated with their babies dying, and this here was babies dying from unsafe cutting of the cord with unsterile blades. And together with the community, they came up with a strategy that resulted in a decrease in their mortality rate. The program we developed was called STORK, which is supportive training, offering reassurance and knowledge. And it uses an online aid, mobile app, mannequins, picture puzzles, one-to-one and small group education. And it comprises these components: bystander life support, choking, safe sleeping, smoking cessation, healthy lifestyles, including perinatal mental health, breastfeeding support, common neonatal problems, and relevant to this conversation is coping with the crying baby. So that's included in our care bundle, which is called the STOP program. We have 2 new additions coming, which is vaccination and domestic and sexual violence. So these are the components that we've included in the STOP program. And I'm going to tell you a bit more about the ICON component in a bit. We do choking, for example, bystander life support. We do it one-to-one with the mannequin. And then on the app, which I've shared with you the link, and I will share it with you in the chat when I'm leaving. We talk them through important information about coping with the crying baby, and we signpost them to ICON material and ICON videos, which are seen there. We are in the process of converting this material into multiple languages so that families who do not read English or do not understand English can listen to this in a different language. So this is an example of our safe sleep training and the picture puzzles that we do. So the target group for all the messaging, including ICON, is parents and families of babies admitted to the unit and any additional parents, carers, and families considered vulnerable. And remember that the messaging that we relate in relation to ICON is offered through our STORK facilitating team, and it's offered on a one-to-one basis with families. And these are considered highly vulnerable families. And here's an example of our poster. We have a collaborative, and we offer this program in other hospitals around the Midlands, and these are named here. And parent feedback for the program has been exceptional. So what did we do at University Hospitals Leicester, and how is it relevant to what I'm going to tell you about ICON today? So last year, we conducted for our unit a total of 708 individual STORK programs, of which 603 were delivered by our STORK facilitators. We had 1,580 babies being admitted to our neonatal service, and these would have been considered highly vulnerable families. What did we uncover? We uncovered that the families using our neonatal services are vulnerable. How did we know that? When we looked at their details and when we analyzed the audited information, we found that 1 in 2 came from an ethnic minority grouping. That means the mother was of ethnic minority. 1 in 5, English was not spoken as the main language at home. In 1 in 2, the baby on the neonatal unit represented the firstborn baby. In other words, there were families that were going to have more babies. In 1 in 3, the highest decile of deprivation and education were where these families lived. And 1 in 4 babies were taken home to a passive smoking environment. So these suggest highly vulnerable families and therefore babies being in highly vulnerable situations. When we look at index of multiple deprivation, what you can see is that for total indices of multiple deprivation, 16% or 16.9 or 1 in 6 live in the highest quintile of deprivation, and 30% live in the highest quintile of deprivation for education and skills. So the importance of an education and empowerment package becomes more evident as we try to unwind and untease this kind of data. When we look at the population we offered the program to, we offered a spread that was similar to the total admissions on the unit. So we were not biased in how we offered the program. 53% of them were offered to white British families, with the remainder being a selection of families of different ethnicities. What we found was that there was a lack of baseline knowledge. 26%, 1 in 4, didn't have any knowledge about safe sleeping practices. 1 in 4 had no knowledge of how to recognize signs of illness in babies in the first few months of their lives. 2 out of 3, 64%, had no knowledge of how to offer bystander life support or how to deal with a choking child. And 1 in 3, specifically important to the icon messaging, 1 in 3, 28% of mothers, had no idea of how to deal with a crying baby. So when we offered the program, remember the STORK program comprised multiple components, including icon, we focused on the following areas of knowledge. And as you can see here, while the baseline knowledge was limited, after implementation of the training, the knowledge uptake was up to 100% for safe sleep, 99.7% for recognizing signs of illness, and for the icon messaging, although 28% said they knew, had no knowledge about this before the program, 99.7% found this useful after the program. So we have direct evidence that immediately after offering a one-to-one session through our STORK facilitators using our app and sharing the icon messages, we've improved the uptake of knowledge from 28.4% who had no idea to 99.7% who knew about the crying baby, where to access resources, and the icon messages. And here's an example of kinds of things that parents knew before and parents knew after. And these, of course, are not the same parents. So important to look at what parents knew after. So what was learned that was not reflected in information volunteered to the facilitators before the training. Parents understood the crying curve, that it was important to walk away from babies, that babies do cry, they knew who to call, and importantly, not to shake baby and keep calm. Now, you might think that these are all very simple, basic messages, but that's the whole point of the icon, that it's consolidating the important aspects around the fact that babies do cry, understand the crying curve, and know how to manage that. So there was ample evidence immediately that babies or parents benefited from the icon messaging in concert with benefiting from information around other important risks, and this is from a highly vulnerable population. What we don't have is information on whether there was retention of the message and behavioral change over time, and that hopefully will be the subject of future research in our area. So with specific and targeted learning and support around reducing risk for mortality, we've shown that baseline knowledge improves. We've shown that there is evidence of impact in multiple ways, some of which I've not shared with you. We've offered this in a multilingual face-to-face format, and we're working towards an outreach program. So what does this mean? Families using our neonatal services are vulnerable. The vulnerabilities extend beyond limited knowledge around ICON, which we've shown, and therefore ICON should be included as part of the bigger picture, addressing vulnerabilities in perinatal health care that contribute to infant mortality. It's based on the principle of proportionate universalism, where you offer support to everyone, but more to those who need it. And how do we provide support for all? At the moment, our service is provided on the neonatal unit and to vulnerable families, and the intention is to expand this program outwards, but that cannot be achieved without funding and without collaborative working. The impact of the program, including the icon message, is that it is useful as a compact one-stop shop. It's easy to teach from. It standardizes teaching. It provides governance in the sense that trusts and users are confident that the information is standardized and in one place. Parent engagement is excellent. It's supported by all. And we're beginning to research this through our collaborative. And we're identifying through collaborative work that there are things that we can learn from reducing risks. And in summary, we know that our families are vulnerable. We also know that the icon messaging is making an impact, but it cannot be a standalone learning package. It has to be part of a bigger bundle of care. So thank you very much for listening to me, and I'm happy to take questions.
Thanks, Tilly. That was really, really great presentation, really interesting. And it's good to see that it's one-to-one and obviously the results of the parents after they've had the, the education. You said about mothers. Does fathers get that as well? Because it said just mothers.
So I haven't showed you data, but we have,
Okay.
when we do the program, we include fathers, we've had grandparents, uncles, aunties, and siblings join. So that data is available as well.
Oh, that's
It's
brilliant.
not just mothers.
Yeah, I thought not, but I just thought I'd ask. That's really useful. And like you say, parents of new babies are very, in neonatal units, they're very anxious and very vulnerable, aren't they? So having that one-to-one, I think, is really, really helpful. Hi, Sue.
Hi, Tilly, and thanks very much for that. It was a really clear presentation, really interesting. You mentioned about future research looking at behaviour change and retention of the message. Have you any idea of timescales when that might happen?
Yes, so we're working with the relevant organizations to begin that, and I'm hoping that ICON will be a collaborator on that piece of work, because that's really going to be important, because it's not just one message, it's a whole package of care. I would imagine that in the next 12 to 18 months, we'll have something off the ground. 12 months, I'm hoping.
Brilliant.
And
We'll
I'll be in touch.
with you on that.
I'll be in touch.
Yeah, and to see that data about the other people as well who you spoke to as Sue has raised there would be fantastic as well.
I'll send that on with as an adjunct to the slides.
Lovely.
Brilliant.
Thank you so much.
Has anybody got any further comments or questions? As I say, often people haven't and may think things later on and email me, in which case I'll forward that on to you if anybody does contact me later, Tilly, if that's okay with you.
That's fine.
And I'm just going to put the link for the evaluation in the chat box as well, if everybody wouldn't mind just spending a couple of minutes completing. The evaluation is for each webinar, not for the whole week.